After a long time, can we just introduce whoever's online right now?
Oh yeah, of course, yeah, please.
Before we start recording, while you're setting up?
Yeah, that's fine. So I'm Mansoor Ali, one of your DOW batchmates. Come on, Naseem, go on.
Yeah, I'm Naseem, one of the organizers for this.
Okay, so
we have Tahira here, we have Ali Imam, we have Aman, Amir Ghangru, Farjad, Sarosh, Farheen, Maaz Abid, Mesam, Mashood, Waqas.
Naseem, what Samia says, she's been a long time, so she just wants people to introduce themselves and just say where they are. So let's start with people then. Yeah, come on.
Yeah, go to the list.
Right. So am I first? Right. Okay.
Yeah.
So I'm Tahira. So I'm Samia. Hi. I don't know whether you remember me or not, but I used to be with Shama, and I'm in UK at the moment, and I'm a GP here.
Oh yes, Assalamualaikum Tahira. Of course I remember you. Gigi,
yeah. Nice to see you.
Nice to see you.
Come on, guys. You don't need introduction. Come on.
Uzma?
Hey, Samia, Uzma here. I hope you remember me too.
Yes, I do. I'm so happy to see you.
Yeah.
Uzma, where are you?
Welcome, assalam. I'm in Toronto, and yeah, I'm working in clinical research right now. I have some plans for the future, which I might discuss later.
Absolutely. Mashallah, Mubarak. Congratulations. So nice to connect.
Yeah, thank you. Yeah, same here.
Ali Imam is the next one on the list, I can see.
Yeah, so I'm here in Boston. I'm a family doctor here since 2008.
Assalamualaikum, Ali. Rosh, I see you next.
Hello, this is Sarosh. And I'm in Karachi, working as a general surgeon in government hospital. That's it.
Mashallah, wonderful. Great to connect. And Farjad, I see you also.
Hi, I'm back in Karachi for the last 5 years. I am working in civil hospital in the Department of Anesthesia and Surgical ICU.
Wonderful, mashallah. Great. Following in your father's footsteps. Excellent, mashallah.
Yeah.
Great. Nice to see you. And Shiraz?
See you.
I think he's the only one left.
Yeah, assalamu alaikum. I am currently in Indiana for past several years. I'm a hospitalist physician. Actually, I'm planning to move soon towards probably Illinois, more close to Chicago. So I hope you guys know what a hospitalist physician is.
Yes, wonderful, great, alhamdulillah, wonderful, mashallah, assalamu alaikum. Well, great to see you. Okay, all right. Whenever you're ready to start, Mansoor, then I can start and I'll introduce myself to be part of this.
I think we're about to start. Naseem, do you want to start officially and then say this is the last webinar of the year? And yeah.
Actually, I had already hit the start button, and so it's been recording for.
Oh, it's been recording. Okay, all right.
But it's all right. We'll make a formal start. So, hello guys, hello everyone. This is DOW 2002 CPD webinar series. We, as you know, we hold these events once a month, and this is the last webinar of the year. And so we have got a couple of interesting things today, apart from obviously 2 very excellent presentations. We have got a quiz and some, we will announce the names of the best speakers who gave talks during this year. So thank you very much to Samia Ahmed and Mashood for agreeing to give us a talk today. So the first presentation is from Samia, who is Assistant Professor of Pediatrics in the USA, and she's going to talk to us about obstructive sleep apnea in children.
Thank you so much for the introduction. Thank you very much. Jazakallah khair. Assalamu alaikum. Thank you, Mansoor, for the invitation. Yes, my name is Samia. I was Samia Shamim when I was in college. So I'm Samia Ahmed now. And like an assistant professor of pediatrics, I trained in pediatrics and child neurology and sleep medicine. I finished my training several years back in Houston at Baylor College of Medicine, and I moved to San Antonio about 7 to 8 years ago. And since then, I've been working at the Children's Hospital of San Antonio. I'm still employed by Baylor College of Medicine, and I practice both child neurology and sleep medicine. I'm a diplomate of the American Boards of Sleep Medicine, Neurology, and Psychiatry with special qualification in child neurology. So it gives me great pleasure to talk today about obstructive sleep apnea and its repercussions. And because we only have 20 minutes, I'm going to just kind of focus solely on that because the time is very limited. Okay, so starting now with goals and objectives, to recognize when to evaluate for obstructive sleep apnea, we'll call it OSA. And at the conclusion, we should understand the clinical significance of sleep disordered breathing and also understand the management concepts of OSA. So what are sleep-related breathing disorders? They can broadly be categorized into primary snoring, obstructive hypoventilation, upper airway resistance syndrome, and OSA. Like I said, we'll concentrate on the OSA, but just to briefly tell you, primary snoring is when there is snoring, but there are no ventilatory abnormalities, namely no apneas, hypopneas, or any gas exchange abnormalities. It's quite prevalent. About 11% of children between the ages of 1 to 9 snore. Hypoventilation is when there is snoring, but there's also changes in the gas exchange, and there's a certain percentage of the total sleep time, about 25%, that is spent with transcutaneous CO2 levels elevated. Upper airway resistance syndrome, they may not have the snoring, but they do have the repercussions of sleep apnea. They may not even have the apneas or hypopneas, but they do have the day and nighttime, the daytime symptoms, and we will go over some of those symptoms. And OSA is the constellation of both nocturnal and diurnal symptoms, the risk factors, and the ventilatory abnormalities. And so as I go forward, I'm going to go through each of these, what these symptoms are. Okay, just to go over a little bit of the epidemiology of OSA first. OSA occurs in about 1 to 5% of children, with a peak incidence between the ages of 2 to 6, and this correlates with the maximal size of adenotonsillar tissue. Major risk factors include obesity, but also allergies or asthma. Certain races, just because of the facial features, such as maybe a larger tongue or a flatter midface, can be more prone to OSA. As can a family history of OSA and things like reflux or velopharyngeal cleft palate repair, or if there is any chronic nasal obstruction and mouth breathing. So what are these symptoms? Well, nighttime symptoms include snoring, which is fairly often, more than about 3 times per week, mouth breathing, coughing, pauses in breathing, these are called apneas. And there's a special definition for it, like how long and how much of a decrement in the effort. Also restless sleep, sweating, enuresis, and parasomnias. So anything like sleepwalking, confusional arousals, night terrors. Now the daytime symptoms, it can include inappropriate napping or daytime sleepiness like in adults, but children more often will present with inattention, behavioral problems, and learning problems. So how is this evaluated? First and foremost, of course, by a history. When I start with the history, I will start with a certain time of the day, such as if it's school-going children, I'll ask them what time do they come home from school, and if it's a child who's at home, I'll say maybe what time do you have dinner. Then I will ask each of the events leading up to bedtime, how much television or use of electronic devices, what their routine is getting to bed. Where are they sleeping? Do they fall asleep by themselves? How long does it take for them to fall asleep? How many times do they wake up at night? What time do they wake up in the morning? And do they have any scheduled naps? Also, the examination focuses more on the head and neck. And specifically, we look at, if the nasal septum is midline, or if there's any enlarged nasal turbinates, if there is enlarged tonsils, we grade the tonsils. Over here, you'll see the Mallampati score. A higher Mallampati score is associated with higher chances of having obstructive sleep apnea. Mallampati 1 would be where you can see the soft palate and the hard palate, the pillars, the fauces. And then Mallampati 2 would be if you cannot see the entire uvula. And then Mallampati 4 would be only if you see the base of the uvula, and Mallampati 5, you only see the hard palate. Then we can also do a sleep study, also called polysomnography. And a polysomnography is an attended overnight study, and I'll show you some pictures and which leads are applied. Some alternatives are home sleep apnea tests, shortened tests, and sometimes you can even just ask them, can you show us a videotape of how they sleep? Of course, the gold standard is an overnight polysomnography, attended polysomnography. There are some sleep questionnaires like the OSA 18, which can pick up some more common causes or some very high-risk patients if you don't have access to a sleep lab. They are kind of harder to come by. The wait time for our pediatric sleep lab is about 2 months. Okay, so what does the PSG setup entail? So there are some leads around the eyes to look for eye movements. There are some on the scalp to pick up EEG, a normal EEG. So we have 21 channels on a routine EEG, but a sleep EEG will only have about 6. You're basically just looking for different sleep stages. Then there are 2 leads around the nose. One checks the temperature of the air that goes in compared to the temperature that comes out. So it'll be warmer when it comes out. And if there's not much of a change in the temperature, that'll indicate that there is not much airflow passing through the nares. There's another one that actually checks the flow. So there are 2 around the mouth. There's another one by the chin to check for chin tone. So if there's decreased chin tone, that helps us understand when the patient has a REM atonia, and thereby it helps us in staging REM sleep. And of course, there's EKG. There's also chest and abdomen valves to see how much effort there is when they are trying to take a breath. And then there are limb leads on the legs to see if there are leg movements. So all of this is put together, and the child is asked to lie down flat on their back, and there's a video camera as well, and they sleep. So you can understand this is not the most natural way to sleep. And of course, if we have any child that has any delays or any other, behavior problems, it can be very challenging. Okay, so what are the diagnostic criteria? First, you have to have the clinical criteria and then the polysomnographic criteria. So clinically, they should be snoring about 3 times per week. They have labored or obstructive breathing, and then they have the daytime symptoms we talked about. Polysomnographically, children, they can, if they have more than 1 obstructive apnea or hypopnea per hour of sleep, that is enough to diagnose them with obstructive sleep apnea. I know in adults there is different criteria, at least about up to 5 are accepted as being normal. Then you can also look at the pattern of hypoventilation. And I had mentioned if the PCO2 is over 50 for about 25% of the total sleep time, they may also have obstructive hypoventilation. So apnea, like I said, on the sleep study, the apnea means that there's at least a 90% drop in airflow for at least 2 breaths. And this can be either obstructive, central, or mixed. Obstructive means if there's no effort. So if the chest and abdomen belts are still struggling, but the nasal leads do not show any airflow, that would be an obstructive apnea. Versus a central, you would not see any effort on the abdomen or chest belts either. And a mixed would have both. Hypopneas. So if an event does not have at least 90% drop, and if it's maybe just like more than 30%, that is a hypopnea, so a lesser degree. And then the AHI that is calculated is the apnea-hypopnea index. That is the number of obstructive and central events per hour of sleep. So this is just a pic from a sleep study. This would be the EEG leads, the eye leads, the EMG, the limb leads, EKG, nasal and oral, chest and abdomen. This one doesn't show a CO2. But here you see the chest and abdomen still struggling to take a breath, but over here you see an apnea. So this is a obstructive apnea. Versus a hypopnea, again, you have the effort here, but this is not a 90% decrement. Okay, so upper airway obstruction, what are the causes? In children, the #1 cause is adenotonsillar hypertrophy. Oops, sorry, pardon me. But also reflux, allergens, nasal septal deviation. A big problem these days is becoming obesity. And of course, if you have other upper airway problems, so this would be like a 4+, kissing tonsils. So what is the pathophysiology? So say somebody is sleeping, okay, they relax, their lung volumes start decreasing, the upper airway, as it starts narrowing, there's increased upper airway resistance, decreased chemosensitivity, and they start hypoventilating. Then the airway eventually collapses, and this is the apnea or the hypopnea. So this is like someone is being suffocated. So of course the response is to try to breathe harder, okay? Because the oxygen is decreased and the PCO2 has risen, and this causes an arousal. So then there's rapid opening of the upper airway and the person overbreathes, they breathe off the CO2 and they increase the oxygen, and now they fall asleep. This cycle repeats itself again and again. So when you say AHI of 1, that means like every hour of sleep, this is happening once. If they're being, they're struggling to breathe, they arouse, and then they go back to sleep. Now, mild is 1 to 5 events per hour of sleep, moderate is 5 to 10 per hour of sleep, and severe is more than 10 times per hour of sleep. So if this is happening 10 times per hour of sleep through the night, every night, you can imagine how fragmented their sleep can be. Okay, what are the sequelae? So this is kind of where I wanted to concentrate a bit more because many people do get the impression that snoring is just a part of life and it's not very significant. So in children, we worry that there is neurocognitive dysfunction due to the sleep fragmentation that I mentioned. And this intermittent hypoxia leads to systemic inflammatory vascular changes in the brain. Also, this can cause metabolic dysregulation, leading to insulin resistance, lipid homeostasis alterations, metabolic syndrome, and failure to thrive. And over time, there can be cardiovascular complications, including systemic hypertension and right and left ventricular hypertrophy. So the neurocognitive effects, there is increased subjective sleepiness and mood problems, irritability, fatigue, having tantrums, but also deficits in attention, executive function, and memory. There's a longer reaction time, more hypervigilance, and there's sustained and selected attention. There are no consistent delays in language or impairments in visual perception or motor function. And there is an association between low academic achievement and sleep-disordered breathing. This is fairly well studied. What are some of the externalizing behavior problems? Well, they can be impulsive, they can be hyperactive, aggressive, have oppositional and conduct problems. Also, they can have some somatic complaints or social withdrawal, and their quality of life is negatively impacted. And this, of course, if a child is not sleeping well in the home, of course, I think anybody with kids would know that the parents and caregivers or even the siblings may not be sleeping as well. And in fact, studies that have been done show that there are similar decrements in quality of life in those as with chronic medical conditions. What about ADHD and academic challenges? So there's a prevalence of about 18% of significant sleep disordered breathing symptoms that have been studied who are in the lowest 10th percentile of their class. And then about as many as 25% of children with ADHD snore. So one of the evaluations for ADHD should always include a careful sleep history, and if there is snoring, evaluation of their sleep. Up to almost 30% of children who are scheduled for adenotonsillectomy meet the DSM criteria for ADHD, compared to only about 7% of otherwise healthy surgical controls. The 1-year post-op TNA, 50% of those children post-op no longer met the criteria for ADHD. And the ADHD score is actually normalized in about 78% of 40 children who had undergone TNA in about 6 months prior. So there's actually no direct correlation between the disease severity and the oxygen saturation and the behavior problems. Okay, so severity, you could have mild OSA and still have pretty significant problems. Neurobehavioral deficits are associated with primary snoring, are also similar to those with OSA. And the speculation is that there might be a genetic susceptibility, some environmental influences, comorbidities that may also influence neurocognition. So what is this impact? So there have been a lot of studies, and including one in which they looked at, does normalization of PSG, that if they normalize just the PSG parameters, this did not predict functionally significant improvements. but it did improve parameters such as quality of life. And there are two theories, either the disruption of the sleep architecture by pulse transit time and the cycling alternating EEG patterns. Also, there is the lack of improvement in neurocognitive measures, despite improvement in respiratory parameters in some children, may imply that the associated deficits may not be fully reversible with treatment in high-risk population. Just keep in mind the high-risk population may have other risk factors as well. Okay, so what is the pathophysiology? Why does this happen between OSA and the cognitive dysfunction? Well, the recurrent arousals will cause this sleep fragmentation and the daytime sleepiness, and the intermittent hypoxia causes this systemic inflammatory and vascular changes in the brain. And sleep fragmentation actually has preferential effects on attention, whereas the intermittent hypoxia actually affects more of the executive function, so the frontal and the prefrontal areas, rather than maybe more of the hippocampus, where the attention. So what goes on over here? So when there's restrictive sleep, this causes disruption of the restorative features of sleep. And intermittent hypoxia, again, affects preferentially the hippocampus and cerebellum, and this together will cause oxidative inflammatory changes that lead to actually structural and neurochemical changes in the hippocampus and in the prefrontal cortex. There are some markers that you can look at, CRP, interleukin 655, and insulin-like growth factor also. I think I might be coming low on time. So am I out of time, Mansoor? I think I'm.
You can take a couple of more minutes.
Oh, I actually have about 2
minutes.
minutes left. I have about 2 minutes left. Okay.
Yeah, 2 minutes.
Okay, so just wanted to understand this obstructive sleep apnea. There's this hypoxia, hypercapnia, and vaporfusion. So this causes sympathetic activation, and this can cause increased catecholamine release, increased cortisol, and this leads to endothelial dysfunction, atherogenesis, hypertension, and causes the increased cardiovascular risk. Again, this is more in the adult population. Adults tend to have more severe sleep apnea versus children, but this is the reasons why we say this happens. Also, all of these factors can cause pro-inflammatory activation, release these cytokines, and they can also cause altered adipocytokines, which cause increased weight gain, increased appetite, impaired glucose tolerance, and diabetes, and have this cascade of problems. Bedwetting actually is very common, and there are, this is because of changes in intrathoracic pressure and release of atrial natriuretic peptide. If you treat it by adenotonsillectomy, the bedwetting actually resolves within about a month. About 25% of children who have OSA have bedwetting as well. Growth failure, some of the small medically complex ones, you improve their sleep apnea and their growth can improve. Remember, growth hormone is released during slow wave of sleep. If you are not getting the good slow wave of sleep, the growth hormone is not released as much. There's also an increase in partial arousal threshold. So of course, me being as a pediatric neurologist, poor sleep leads to increased risk for having breakthrough seizures. Treatment, number 1, treatment in children is adenotonsillectomy. Number 2 is CPAP. Adults, the first line treatment is CPAP, not adenotonsillectomy. And there's a few other things, weight control, oral appliances. Success rate is very variable for adenotonsillectomy. Okay, that was my timer.
All right.
And yeah, that was my own timer going off. Okay, adenotonsillectomy has a variable success rate, so often you should repeat the sleep study to make sure you have adequate resolution of the OSA, particularly if you have in the moderate to severe range. Also, there is a very famous study called the MCHAT, where watchful waiting versus TNA. In this study, they said that surgical treatment did not significantly improve the attention or executive function, but it did reduce symptoms and improve the secondary outcomes of behavior, meaning the quality of life and the polysomnographic findings. They said, however, normalization was also found in almost half of the watchful waiting group at 7 months. Therefore, if you are on the borderline, there's some concern, you can also just do watchful waiting, and you can do some medical treatment like intranasal steroids or leukotriene inhibitors like montelukast. Okay, I think I should probably stop. CPAP, weight management, oral appliances, pharmacological, positional therapy. The best position to decrease, to improve breathing when we sleep is in the lateral position. And there are just different ways. There are some belts and things people wear to make sure they sleep on their lateral position. Supplemental oxygen, very rarely used, more so in maybe like the neonatal population, where the oxygen is actually acting almost like a CPAP mechanism, and it's a temporary bridge. Often because under the age of 2, and particularly under the age of 1, they cannot actually have much surgical intervention for treatment. Bottom line, sleep is important for the developing brain. OSA can cause sleep fragmentation, metabolic and cardiorespiratory disruption that can have serious consequences. Detection and treatment can lead to improved health and neurocognitive outcomes. Thank you very much.
Thank you very much, Samia. Very good, excellent talk.
Sorry, I went over time. Sorry.
No, it's fine. So very, very good talk. Excellent. We'll take questions, I think, after the quiz. So if you just stop your screen share, Samia, please.
Yeah, sure.
So our next speaker is Dr. Mashood Sajjad, who works in the US, and he is a diplomat of American Board of Internal Medicine. Thank you very much, Mashood, for giving us this talk today. Very important topic, preventive medicine for adults.
Okay, so I can start, right? Bismillah ar-Rahman ar-Rahim. Good morning, good afternoon, and good evening everywhere. Okay, I'm Mashood Sajjad. You guys can hear me, right? Right?
Yes, we can.
Okay, good. So this is the topic that I choose it because of multiple reasons. Okay, one is what we needed in our practice. I mean, our means mine or anybody who is doing as a GP. What are the main reasons why we are doing the medicine and providing the best care to our patients, and go from there. And another reason what I am providing is to see if somebody want to do a private practice from now on, so they can learn from this motto and can do whatever they want. Okay, so start from my first goal. I initially started as a hospitalist almost 10, 12 years ago, and I was working only as a hospitalist. So I have no clue about the primary care, what's going on, how we just admit the patient, take care of the acute issues, and then move on. Okay, so the continuity care is not there. So when I decided to move into the primary care, at that time, I decided how I can make it different as compared to the other primary care, because there is a lot of 100,000 people, 100,000 doctors who are doing the primary care. What I can do different so people can come to me more than somebody else. Okay, so this is my motto when I started the private practice, that okay, I can provide the best care. Anybody can provide the best care too, but what's the difference between the me and the other? What I think. Okay, so I try to do the comprehensive care, which means I see my patient in the hospital too, and also admit my own patient in the hospital. What the biggest problem, what I noticed after starting my practice, is when the patient go for the acute problem in the hospital, when they come back, there is a lot of changes happen, and the doctors in the hospital take care of their stuff, and we don't get enough data or enough information what happened in the hospital. So it's difficult to manage. The other thing is easily accessible, and the other thing, the last one, is like you have to be lucrative, otherwise you cannot run your practice as a private practice. Okay, so this is what the preventive medicine is. Okay, the preventive medicine can be divided, you can, in a 4 big category. One is the primordial prevention, which is like anybody, you can make a changes in the childhood. For example, if we started to take care of stuff in a kids, like eating pattern, physical activity, not having too much screen time, smoking, we should stop smoking during the high school or med school rather than stopping after the age of 40, because the damage is already been done. Okay, the next one is the preventive primary prevention, like action we take prior to the onset of the disease, which I bolded, so you can say like immunization or something like that, you can do it. The secondary one is the action which halts the progress of the disease. For example, for the breast cancer, you can do the mammogram to prevent that one. And the last one is the tertiary prevention, which means the disease is already happened and you started to have a complication. So all the measures you can take it to reduce the impairment or the disability, especially in the end-stage renal disease patient. And the most common, as you know, the most common reason for the end-stage renal disease in the world is like diabetes. So you need to take care of the diabetes under control and the complications. So you go from there. Next. So prevention is the best than cure. Everybody know that. Okay. So the topic that I'm going to talk today is like vaccinations, like a screening tool, screening for the colonoscopy. In a cardiovascular disease, you can use aspirin and check the lipid panel. You can do the EKG, echoes, stress test, and abdominal ultrasound for AAA. This is the most important recommendation. For diabetic patient, I usually recommend my patient according to the ADA, like you have to have a fasting glucose check, hemoglobin A1C, creatinine, like kidney function test or GFR, whatever you call it, a microalbumin level, eye and the foot test. Okay, so I mean the retinal exam need to be done every year. Okay, and somebody who come to you and has obese with the BMI greater than 30, you should look into these things for preventions. Okay, so vaccination, I usually deal with the adult patient, not with any pediatric population. So I am talking mostly vaccination related to the adult rather than any pediatrician here. Okay, so Tdap or DT vaccination need to be done every 10 years, all ages. And DTaP, you can do one time. After that, you can move it to DT. That's a recommendation now. Influenza vaccination every year, all ages, no exclusion or anything unless you're allergic to eggs or you have a history of GB syndrome or something like that. Okay, pneumonia vaccination usually recommend at the age of 65. There are two vaccinations in America. One is Prevnar 13, which is the relatively new as compared to Pneumovax 23. If a patient has a diabetes, heart, lung, or liver disease, any failure like heart failure, lung disease, chronic COPD, emphysemas, liver disease, cirrhotic or anything, pregnancy, or healthcare professions, okay, they should started that vaccination at the age of 60 or earlier, depend on what other risk factors are. Shingles vaccination, there are two vaccination in US. One is called Zostervax, one is called Shingrix. Both recommended starting at the age of 50. Okay, Zostervax only one shot. Shingrix has two different shot, 3 months apart. The big thing about the shingles vaccination, most of the patients come to me in my office and says, okay, why should I get it? So the main thing what I tell them is, a study shows Shingrix or Zostervax, they do not decrease the incidence of the disease, they decrease the severity of the disease. Okay, so I want to make sure them they understand, but because 4 months or 5 months or 6 months later, they come and say, okay, you told me this vaccination should save me from this. Yes, it's going to decrease the severity, not the incidence by the studies. Okay, the next one is HPV, which you can start at the age of 9. Okay, usually people start at the age of 11 and 12, and female and male, like you can see on the screen. And the other one is the actual influenza, meningococcal, gonorrhea, mostly immunocompromised, splenectomy people and everything. Meningococcal is also, if you're going to the Middle East, especially for the Hajj or Umrah, you have to have it, that one done also. You guys know that, okay. Screening tools, we're talking about everybody, whoever come to office should have their blood pressure check, regardless whatever their age are. Next is fasting blood glucose level, especially if your BMI is above 30. Okay, that's the recommendation now. Okay, hemoglobin A1C can be checked with the BMI higher, but it's usually recommended for anybody who is high susceptible for the diabetes. In diabetic patient, new ADA guideline is you have to check hemoglobin A1C either every quarterly or 6 months, not every year. It's supposed to be a little bit quicker. Okay, thyroid function, you can check it in obese people, fasting lipid panel, annually recommended between the age of 40 and 75. Microalbumin recommending in diabetic and renal patients. Diabetic patient now is a semi-annually. Retinal exam annually recommendation for the diabetic retinopathy. Foot exam, which is the monofilament test, which is just physical examination. And then I do in my office called ANS and see the motor function test, which is, I will show you the picture of that one, which is one of the tests, one of the studies shows that it detect early diabetic peripheral neuropathy and autonomic dysfunction, which is very common in the diabetic patient. I will show you further down in the presentation. Okay, next is the DEXA scan or bone density test, which is recommending every 2 years, and then you have to calculate the FRAG score. And normally I recommend to start it in the female at the age of 65 or older, but if females have early menopause, either hysterectomy or both ovaries are out, so they recommend at the age of even 50. Depend on when the hysterectomy and oophorectomy has been done. Male, I usually recommend at the age of 70 or older. Anybody who's a higher risk factor, which I told you, like female have early menopause, should be started at the age of 50. Okay. Okay. In America, most of the doctors or most of the physicians usually use JNC8 guideline, which is the latest one. Okay, so I just put it there. Number one thing is, even in the board exam and everywhere, they ask if you see on the right lower bottom lifestyle changes with the smoking cessation, control blood glucose, lipid, dietary changes. No desi food. I'm just kidding. Okay, and the other things, these are the main goal everywhere. And if you follow the path, is like general population. If there is no diabetes or anything with the age greater than 60, you go with the goal of this, which is less than 150 over 90. And if you go to the JNC 7, that was not there. This is according to JNC 8. And if it is age less than 60, your goal is around this one. If you have a diabetes and coronary artery disease, all the ages, diabetes present, no CKD, then the goal is this one. And if you have both things, then you go with there. And initial treatment with the ACE and ARBs, or in combo or alone by itself, can be used. Right now, if you go here, with the general population, you can start these choices and go from there. So next, this is the study done for hypertension to compare what an American College of Cardiology, American Heart Association versus the European Society of the Cardiology and European Society of Hypertension. If you see, there is a little bit difference here, level of the blood pressure defining office or clinic. In America, this is 130 or 80, and here they keep it at 140 and 90. Okay, daytime mean should be this, nighttime mean should be this, 24-hour this. Home BP monitoring is the new thing that very hot topic right now, and they are using ambulatory blood pressure devices, which are even billable right now. People are using it. I don't know a lot about that one, so I did not include that one. Once I know, I will let you guys know. Okay, so this is the difference between this. Okay, the important thing you can see in this, take BP at home twice in the morning and twice in the evening in the week before clinic. Bring the BP machine in the annually for validation. This is the most important things that I tell my patient. They have a machine, they come, they says, okay, my blood pressure is fine at home. Okay, when I come to my doctor's office, it's a white coat syndrome. I say, no. Bring your machine and let's compare it with your machine and our machines. If the numbers is really different, then okay, I can say you have a white coat machine, a white coat syndrome. But if you're not, then we have a problem with your machine. So change your machine. I usually recommend to change the machine every 2 years, at least. Every year, that's fine, but every 2 years should be changed because machines are not that error-free. Okay, so this is what I do in my office. These are the two diabetic things which are very important, and people want to come to your office rather than going to ophthalmologist and having an extra visit and everything. If you see on the left side, this is the very small like a camera with the lens, and it's take your retinal picture. Okay, and it's gonna come, I will show you later. So my MA medical assistant can take this picture very easily. Just dilate the pupil, and you can take the picture, and then picture goes to by a website to ophthalmologist. He look into the picture. You can look at that too, and they will recommend either you need to see any ophthalmology for the treatment, or you don't need it and come back in a 1 year and get another done because you need every year examination. Okay, foot exam. This is also, as I told you, is a pseudomotor system, okay, in which you can see for the neuropathy. Let me minimize that one and share these things. Okay, so this is how you, can you guys see that? Hello?
Yeah.
Okay.
Yes.
So this is how you see.
Yeah.
Okay, so this is how you get the result of this picture. It's not, it's the sample of that one. There is no real patient or anything like that. So this is how you get the picture of retina right here. Okay, and you can see there is a difference between the left and the right. Okay, and right here you can see. Okay, this is the, no, sorry. And this is the machine we used for autonomic system, which give you a detailed report. If you see on the top of that ANS1 status report, and then it's give you this 11 different things which include autonomic dysfunction. If you see here, it is they show here is small fiber neuropathy, okay, microcirculation, arterial stiffness, high blood pressure, and everything. And this is the article. You can see this one, right? This article.
Yes.
Yeah.
Okay, so this is the detection of the article. I just put it there, just if somebody need it, they can look at that one. So detection of neuropathy using pseudomotor function in the type 2 diabetes. Okay, and if you go the conclusion, I mean, it's a very good test to understand and show to the patient what's going on. In addition to, it give you a good reimbursement too, by the way. Okay. Okay, so this is the FRAG score, which
So
I
you have
talked
2
about.
minutes.
Excuse me?
You have 2 minutes.
Are you kidding with me? Okay, so I'm trying. Okay, FRAG score is, you can use it. Okay, let's go with the screening of this one. Is screening for the cancer. There is a colon cancer, prostate, and everything. Let's go for. So there are pros and cons of screening. Which means you can see the benefit, reduce the cancer incidence. Okay, if you go to the potential of the harm is like you create an adverse event, you can give you false positive, anxiety, and create a lot of trouble too. Okay, let's go with the colon cancer. Colon cancer, this is what I want to really talk about, that one. Okay, colon cancer is like everybody recommend to have a colonoscopy at the age of 50, regardless whatever it is. Okay, at the age of 40, who need to be at the age of 40? If you have one first degree relative, or you have a 2 secondary degree relative, even if their cancer was diagnosed after the age of 60. Okay, when you need at the 40 or the younger than 40 is when you have a one primary, one first degree or 2 second degree, they were diagnosed at the age before 60. Okay, and then go on with 25 years or younger. You usually do with the hereditary non-polyposis people. Then you do every 2 years, and then till 40, and then you every year. 16 to 12 years, if somebody has a familiar polyposis, that's what the recommendation is. If you have a colon cancer, need to have a colonoscopy every year, then every 3 years, then every 5 years. And if you have ulcerative colitis, Crohn's disease, you have to do colonoscopy after the age of 8 years from the diagnosis, and then every 2 years, 1 to 2 years. Okay, this is a colonic polyp. If you have a different polyps, whatever the size, whatever the quantity, you go according to their recommendation. This is the prostate cancer screening. This is the second most common type of cancer in the men. It used to be number one. Now lung cancer bypass that one. Screening usually recommended at 55 to 69. High risk patient can get it done at 40 and 60. Usually we need to discuss with the patient before we ordering the PSA or something, because the false, if you see the some men, there is false positive and there is no benefit. According to US PSTF or American Urology Association, if the patient requests, do it, otherwise take it easy. Okay. Breast cancer is the most common cancer in the female. Lifetime risk factor developing an invasive cancer is 12.5. Personal or family history, if somebody has it, they have the high risk. Age above 50, if somebody has the BRCA1 or 2, is a high risk patient. Other risk factor, you can see that one. US PSTF or American College of Family Physician recommend a screening start at age of 50 to 74, which need to be done biennially. If you have American College of Gynecology, recommended screening start at 40 and 40 to 74. It's depend who you want to listen, who you want to follow. It's everybody recommending a little bit different, but not that vast difference. Okay, this is the breast cancer risk assessment tool. If somebody has these risk factors, they are a high risk people, so need to be started earlier rather than later. Okay. Cervical cancer usually started, screening started at the age of 21 to 29. It was different recommendation before. Now recent one is like this, started at 21 to 29, only pap smear every 3 years. No need for HPV DNA unless you have ASCUS. Okay, age 30, you need both. Okay, and then you need every 5 years. Age of 65, no further need if you have a last 3 paps negative, and a high risk patient need every year. Okay, for the age above 30, if you have, you can follow this guideline. If ASCUS and HPV positive, then you do the colposcopy, and if HPV negative, no colposcopy and repeated PAP. And if you have ASCUS is negative and HPV positive, no colposcopy, and go from there. Only if somebody has a hysterectomy, only need a pap smear if the surgery is done due to the cervical cancer. This is the most common thing I see in my practice. Patient has a hysterectomy and they go to the GYN and is still getting the pap smear, no reason. Okay, lung cancer is the most common cancer. Give me 1 minute. Okay, this is the last one. Okay, this is very important one. That's what I'm saying. Lung cancer is the most common type of cancer in the men. USPSTF recommend annual screening for lung cancer with the low dose CT scan. Okay, especially in the people who is age between 55 and 80 with the 30-pack year history, currently smoking, or quit within the past 15 years. Okay. This is the guideline from multiple association and societies, what they're talking about the low dose CT scan. According, you can see on the right side, every year they are coming with this one. Some people says yes, some people says no, high risk. If you see over on the top of that one, this is a trial, but the largest trial they got it done, which shows okay, demonstrate the lung cancer mortality benefit of 20% with the all-cause mortality reduced by 6.7%. Okay, this is the lung nodule. If you have a different size of lung nodule or the consistency of the nodule, a different recommendation, everything going this way. Okay, and then I am done. Okay, cool.
Very good. Excellent. Thank you very much, Rashid. Excellent presentation. So, guys, we'll take questions in the end, I think after the quiz. So I'm going to, Mashood, if you stop sharing your screen, please.
Sure.
Okay, so can you all see my slide?
Yes.
Yes, we can see you.
Yeah, okay, right. So the plan is...
Yeah, okay. Have you unmuted everyone?
Yeah, yeah, that's right. So just unmute. Okay. So I've unmuted all of you. Please try and minimize the background noise if you can. And please have a look at your teams. Okay. Now I've just added some more people just as few new folks have joined. And I think if Salman has joined, I'm just going to add Salman to team B. Okay.
I think so. You've mentioned Uzma in both the teams. Can you check that out?
Yeah, you're
Yes,
right.
okay. Okay, so please have a look at the team. So there are two teams. So we are going to have a quiz now, and it's just general knowledge questions, some medicine questions, some related to DOW Medical College. It should be good fun, good activity. And there are two teams led by Samia and Mashood. And I think Farjad is here, Maz is here. Please have a look at your teams. Anyone who is not, if you can't find your name there on the screen, can you please shout out and let me know? I think I've added everybody. Yeah?
Uzma is added twice. Uzma is added
Yeah,
twice.
Uzma in both teams.
Yeah.
She's playing both
Oh,
teams.
got it. Yes. Okay, right.
Well,
Okay.
अरे भाई उस्मा को दो दफा डाला हुआ है.
Okay, yes. Uzma, yeah, Uzma is yeah, everybody is.
ये डार्थ वेडर कौन है भाई?
Oh yeah, that's right. Who is this?
कोई लग रहा है टॉयलेट पे बैठा हुआ है.
And he's watching the new Star Wars movie. He's breathing like Darth Vader.
Okay, shall we start?
Yes, I think we should start. I just want to let you know, Anila Amreen has joined. Anila Amreen has joined from Saudi Arabia. Welcome, Anila.
Anila, welcome. You are in team A. So,
Okay.
नहीं भाई ये तो गलत बात है. अनिला अभी आई है. हमने 20 मिनट मशहूद की प्रेजेंटेशन सुनी क्विज के लिए.
Okay. I think we should start. And guys, just want to let you know that you need to. There's lots of noise. You can just minimize the noise. You need to just ask your captain know the answer, so the captain will have to give the answer. So,
okay, so let me just go through the rules, guys. Please listen very carefully because there is a lot of noise. I know everybody is unmuted. Just listen to the rules very carefully. I hope you know your teams. These are your teams. Okay. So, so we are going to post a question. So the first question will be for team A, and they have about 10 to 15 seconds, and you can shout out the answer. So your captain can hear your answer. If you know the answer, you can shout out, whatever, or consult. But we will accept the final answer from the captain only. So when the captain is ready and captain says, okay, right, this is my answer, we will accept that answer. Okay. So for example, in
suggestion Naseem a suggestion.
the shoot team, there is Sarosh, Shiraz, Amir Ghangru. So it doesn't matter, what they're shouting. You can hear all the answers, and whatever Mashood will say in the end will be accepted. Yeah, guys, is that all clear? Now,
Naseem, can you hear me?
yes, go on. Say.
If the question is for team A, then you can mute. And similarly, if the question is for team B, you can mute team A.
no, we can't do that because there is no option as such on Zoom.
It may be difficult. It may be difficult. Yeah.
So it's almost impossible because either I can mute all of you or unmute all of you, or just mute like few like only the selected person. So
Okay, let's crack on, guys. We'll waive the time as well. Come on, team.
20 questions, 10 each, and the rules are that if you get the answer right, you will get 2 points. If you don't get the answer right, and the other team gives the right answer, they will get 1 point. There's no negative marking. So if you get the answer right, you get 2 points. If you don't know the answer and they get the answer right, they get 1 point. Okay. Now, please, use of smartphones is not allowed. Use of smartphones is not allowed. There's no cheating. Okay. And anyone caught cheating will be expelled permanently, and banned
मशहूर
from
भाई
taking.
तुम तो अभी से चले जाओ भाई.
So,
मैं कंप्यूटर यूज कर रहा हूँ.
Okay.
Okay, right. So the first question is for Team A, and you have about 10-15 seconds.
Okay, come on, guys. So I'll start the questions. Thank you, Naseem. How many members are there in DOW 2000 group, which is our website?
437.
Sorry?
437.
I need the answer from the captain, please.
437.
भाई मशहूर भाई तुम हमारे कैप्टन हो
दे
यार.
दिया, बोल दिया ना 437.
No.
Team A के लिए था ये.
Team, it's Samia's team, please.
Samia's team, Mashood.
Mashood is Samia's team.
मशहूर भी अपनी टीम
I
में.
think whoever is answering should have to specify which team they are from. Actually.
Yeah, exactly.
No, I said specifically the first question is for Team A. Okay, so Samia, what's the answer?
437.
Okay, shall I lock the answer? Team A?
Yes.
Yes, please.
Okay. Team B, do you want to come up with any other guess?
भाई wrong answer है तो फिर जाएंगे.
It is a wrong answer. This is why I'm asking Team B.
I think it's 316. Mashood.
300.
I think it's 316.
Mashood.
Oh, don't second guess.
316. We go with the
316 and Mashood is 316.
Mashood.
Well done, Mashood. Team B gets a point. Team B gets a point.
So Team A
guys.
didn't get the right answer. Team B got the right answer. Team B got 1 point.
Mubarak.
Mashood bhai, we have to win it by hook or crook.
Sure.
बेटा hook or crook.
Next question, Naseem.
Just give me 1 second. I'm just writing the.
So that's going to be our question.
That's going to be Mashood's team's question.
मशहूर
Okay,
भाई
now-
इत्मीनान
now
से ज़्यादा
first-
जल्दी नहीं.
Okay, now this question is for Mashood's team, which is Team B.
Okay, who amongst our colleague has been recently appointed as an associate professor in this specialty?
मशहूर भाई ये मैं हूँ. मैं सब.
Massa, everybody ready? Massa, agree?
Well done, and congratulations, Massam.
Good job, Massa.
Team B got 2 points. Team B got 2 points. Now, next question is
2 + 1 3.
guys.
Okay, question number Team A, Samia, your team. Diagnose it.
This patient has presented with aortic regurgitation.
Marfan syndrome. High cleft palate. High palate.
तो cleft palate है.
High arch palate.
What's the answer, Samia?
I am Asnan, Group A. So
I don't know. Team A, what do you think? High arch palate,
Yes.
crowding,
High arch
aortic.
could be Marfan syndrome.
We needed active here.
Well done, Samia. Well done. Well done.
Well done. The diagnosis is Marfan.
Well done, Team A.
Very good.
Next
Okay,
question.
Team B, Mashood's team. This patient has presented with colorectal cancer.
Acromegaly.
मशहूर acromegaly लग रही है.
Acromegaly. नहीं, लेकिन why colon cancer in acromegaly?
I'll log the answer. What's the answer?
एक chondroplasia है ये.
यार acromegaly लग रहा है मशहूर.
But why the colon cancer?
Yeah, I think so.
Acromegaly बोल दूं?
Yeah, you will.
बोल दे.
Acromegaly by Amir Gangro.
Well done, Team B. Acromegaly.
Correct answer is acromegaly. It is associated.
That's good.
It is associated with
ये मैंने बताया था. मशहूर.
Yeah, well done, hospital internalist. Okay, next question.
Question is for Team A.
Okay, so who has actually come up with the push-up challenge? Name the person, Team A, and when was it supposed to be completed by?
Abdul Fateh.
Sorry, what is it?
भाई ये सामिया की टीम का क्वेश्चन है, बताना नहीं लोगों.
Who has drawn up the 30 push-up challenge And what was it supposed to be completed by?
Abdul.
यार ऐसी हरकतें जनरली स्पीकिंग अब्दुल वाहिद भाई ने की होंगी.
Abdul Wahid.
Supposed to be completed by, I suppose, Hanman. इसके अलावा ऐसी
And we need the answer for part. We need the second part answered as well. Get 2 points.
खुद ही किया था.
हाँ भाई लॉक कर दे यार 50 साल.
यार ये अब्दुल
Wait,
वाहिद
say that again, Samia. Please, can I have silence, please? Say that again, Samia.
I think the first answer is Abdul Wahid. And team, what was the second answer?
Abdul
Yeah,
Wahid
I
as
would
well.
say 30 push-up challenge.
Okay, I'll just say number 30 first.
Okay, so your first part of the question is actually right. It's Abdul Wahid, but it was supposed to be completed by February 2019. So you just get 1 point.
वेडर भाई को तो खामोश कराओ.
The difficult question.
Next question.
Okay, next question, Team B. Who has posted the maximum post on DOW 2002 official website on Facebook? Who has posted the maximum?
Mother, I think
that
can be two. When the number 2 and number 3 can be.
I want one answer, please.
Naseem.
Positive level,
Positivity is too much, right?
And this is for year 2019.
I think
Mazhar.
Final answer?
मजा लग रहा है भाई.
दोनों में से
पॉजिटिविटी है.
What's your final answer? I'll lock it now.
फेसबुक ग्रुप की बात हो रही है. ये फेसबुक ग्रुप की बात हो रही है भाई. फेसबुक ग्रुप की बात हो रही है.
चलो साकिब लगा दो. Saakib.
No, your answer is wrong. It's Naseem Naqvi with 39 posts, Saakib Ghani with 21 posts, Mazhar Mirza with 11 posts, and Nida Ali with 10 posts.
Unbelievable.
Wow.
Don't know about that.
तो ऑप्शन ही नहीं दिया गया.
But you didn't give the chance.
It's Naseem Naqvi.
Okay, next. So this question is for Team A.
नसीम भाई ये तो conflict of interest था आपका.
ये तो conflict of interest है भाई.
No. Questions were made by me. No. Naseem did not even know the answer. Questions were made by me.
अबे ये वही वाली बात है कि.
Okay. Guys,
Next question, guys.
Team A, Samia. Who is considered as the Muslim who introduced science to the Europeans?
Maybe Jabir.
Are we guessing? Otherwise, I might guess like the main law.
I think Jabir bin Hayyan.
What do you think? I don't know. Teenage.
I'm not sure, but I'm guessing Jabir bin Hayyan.
No idea.
You're guessing?
Possibly Jabir bin Hayyan.
Okay. Then teenage answer is Jabir bin Hayyan.
I'm afraid it's Ibn al-Haytham. I'm really sorry.
अरे भाई हमें मौका तो दे.
हमें मौका तो दो यार.
To give team B.
हमारा आंसर था इब्न हैथम.
इब्न हैथम बोलना चाह रहा था यार.
Yes. इब्न हैथम हमारा जवाब था.
हमारा जवाब था ये खा गए.
इब्न हैथम.
1 point 2 में.
1 point.
Ibn al-Hashim in 1965 AD, he was considered as the father of modern optics. And he wrote a book, Kitab al-Nazir.
ये तो बता कितने साल क्या रहा था.
Okay, next question.
Next question for Team B.
Okay, who first extracted digitalis from foxglove plant?
बताओ भाई.
मुश्किल सवाल बोल दिया.
फ्लेमिंग तो
फ्लेमिंग तो नहीं है. वो तो पेनिसिलिन है.
Guess कर दे.
विदरिंग लग रहा है मुझे.
विदरिंग.
Final answer, Masood. What's your final answer?
Second one, withering.
Okay, well done. 2 points there.
Yeah, guys, whoever got it, good job.
Shabash.
Okay, so could you actually tell me, name 3 colleagues who've been blessed with a newborn this year, 2019? Team A, Samia.
Salman at the left.
Who's laughing?
I think one is Irfan.
Saleha, Shazad, right? Shazad, Shamim, and Zishan.
का बच्चा बड़ा है.
यार सालिया और शहजाद हो गए, 2 तो यही हो गए. अब एक बता
Even
दो कोई.
Zishan and Samreen as well.
तालिया शहजाद का छोटा वाला is
दो तो यही हो गए, बात तो सही है. तालिया शहजाद दो यही हो गए.
Final answers, please.
छोटा वाला बड़ा वाला की
भाई कोई और भी हुआ है क्या? हमें नहीं पता चला.
And
यार सालिया को भी नहीं पता.
There's one more. I think Khurshid, right? Khurshid.
Okay, yeah. I'll accept those answers. So I could also add Fahad Wali Ahmad and Amir Zaidi. Thank you.
Oh,
well
2
done.
points. Thank you.
Very good.
Next question.
Next question for team B, Mansoor team.
Okay, who amongst our colleagues has been awarded with PhD this year?
I think Fahad Wali is.
Fahad Wali.
Fahad Wali. Answer?
Fahad Wali bhai.
Well done, Fahad Wali. Well done.
Yeah. यार उनसे आसान सवाल पूछ रहे हो, बेमानी हो रही है.
Fahad Wali, okay, very good. Name 3 conditions that are
Sota syndrome.
Team A, please.
Name 3 diseases that are associated with this
तो
condition.
कर भाई नहीं आया.
If you can give 2 names, that's fine as well.
I don't know. One is probably obstructive sleep apnea. The other is team A. Tell me.
Sorry, what's the question?
Name 2 conditions associated, 2 syndromes associated with this condition.
I can tell, but I'm on the other team.
It's a collapsed nasal bridge.
I know the answer, but I'm on Mashood's team, so I would like to try once they fail.
Right.
Team A, is it team A? I'm talking to you. Is it syphilis for one answer?
Well, one is post-surgical. The other is traumatic.
The other is what?
Surgical and traumatic. Is that what the answer is?
That's syndrome. That's not syndrome.
I think it's associated with the collapse.
Can I?
No, I'm afraid actually we'll have to move it to team B then.
Siraj bhai,
नहीं
answer.
वहीं पे रखो भाई, हमें नहीं चाहिए.
मशहूद भाई, एक तो syphilis है.
मसूद ये चीज़ हम देखते हैं.
एक मिनट, एक तो syphilis है, दूसरा cocaine use है.
What's your answer?
Syphilis तो confirm है.
Very
Syphilis
good.
confirm है.
Okay, excellent. So you're awarded with 1 point.
This is what settle knows. It is associated with cocaine use, epilepsy,
एक traumatic है और एक.
अरे बता हूँ ना मैं syphilis है और cocaine.
जवाब तो सही था यार.
Yes, syphilis. Did you say syphilis? Sorry, I didn't hear you. Did you say syphilis?
I did, man. Mansoor, I did.
Yeah, we said syphilis.
Give them 1 point.
We said syphilis.
Did you guys say syphilis? I have it. Someone said
Mansoor,
syphilis.
Shiraz.
Yeah, we did.
I
They did. Yeah,
I
we did.
I think we should get 1 point more.
Okay, so Mashood will have. Sorry, Naseem will have to give them a point then.
Okay, sure. That's fine.
Did not hear syphilis. Sorry about that.
That's okay.
इंजीनियरिंग हुई है इसको.
Team B.
बंदे ने मुंह काला कराया है.
बस इंजीनियरिंग हुई है, क्या हुआ? बर्न विक्टिम तो नहीं है ये.
Arsenic poisoning, do you think? Arsenic poisoning? No?
Carbon monoxide poisoning.
Carbon monoxide poisoning or arsenic poisoning?
Carbon monoxide poisoning.
What's your answer, Mashood?
सिल्वर पोइजनिंग करते हैं अर्जी.
भाई आवाज नहीं आ रही, सब मत बोलो, एक एक करके बोलो.
अबे मुझे तो नहीं पता क्या है ये.
I don't know. Ma, say it again. Sorry.
अर्जीरिया लग रही है सिल्वर पोइजनिंग मुझे तो.
Which thing? I couldn't hear you. Sorry.
I think he's just ugly.
Age?
Okay, we'll have to pass it on to Team A. Samia, your team.
नहीं भाई, carbon monoxide poisoning.
Emergendos or what do you think? Any idea?
Did you say that again?
Is it carbon monoxide poisoning?
No, that's what we said. We carbon monoxide. Yeah.
Team A, any players?
Sorry, say that
I
again.
think
बस बहुत हो गया भाई अब इनका time.
Samia, I think he's just
I think we
ugly.
should move on.
No, Eller,
maybe.
Move on.
Okay, I think nobody.
Wait, Samia is trying to say something. I can't hear her.
Yeah, Samia, I think it's carbon monoxide poisoning.
You want to try
Carbon
that?
monoxide poisoning. We already told carbon monoxide poisoning.
Yeah, we'll go with carbon monoxide poisoning.
We already told that.
No, okay, so unfortunately, it's someone who's actually taken amiodarone for a long time. Amiodarone-induced
That's Smurf
hypersensitivity.
skin. That's Smurf skin. That's what they call Smurf skin. Yeah.
This is the blue-gray discoloration of the face.
Yeah. It's called Smurf skin. Yeah.
Yeah, it's amiodarone. Yeah. Sorry about that, guys. Let's move on.
So this question is for. Yeah, I think.
That was Team B. So Team A, this is about Dubai 2017. I would like Team A to answer the first two questions. What date was a grand reunion, and name the hotel where the majority of us stayed? This is for Team A. And Team B, you'll have third and fourth question.
So
Team A, first and second part, and Team B, third and fourth.
So it was December.
It was 24th December, right?
I know our answer, Mashood.
Yeah.
Mashood, I know our answer.
So Team A, can I have the answer, please?
Yes, it was not 2016.
And Athona Hotel.
Where was the grand celebration, Siraj?
Sofitel.
Hotel.
Sofitel, right? I agree.
Sofitel was
And
grand celebration.
Cricket indoor
cricket,
stadium.
what arena you played?
I played in Perth.
Yeah, say that again, Samir. For a second, can I actually listen to Samir? Tell me, what's your answer? Team's answer? Atana Hotel, okay. And what date was it?
I'm typing it also.
Oh, typing it. Let me just have a look.
And Team A, tell me the date again. You said something
24th December.
Okay.
24th December, yeah.
Mashood bhai?
Sofitel
Samir, so Sofitel में तो celebration थी.
Sofitel में celebration थी. DIAC Sports था. DIAC Sports.
Atana में तो stay करे थे.
Majority of people stayed in Atana.
Atana.
Grand celebration जो थी वो Sofitel में थी.
Yes, Sofitel is the answer for our first question, and the cricket indoor stadium is the DIC.
Okay. Well, I'll tell you, sir, the date of the grand reunion wasn't 24th of December. It was 23rd December. 23rd. You said 24th, and the name of the hotel with the majority was Atana. So I'll give you marks for that. Atana was right. So one there. For Mashood, yes, it was Sofitel. That's right. And the name of the sports center was actually Active Sports Center, AKTIV. Active.
DIV. That's what we say.
KTIV. Yeah.
Hey, okay, we missed K.
So shall I give them or not, Naseem? They missed K.
Yes, I think we give 1 point to both teams. Yes.
Yeah, 1 point both teams. Okay.
Okay. So the next question is for team A.
Hello.
Mansoor, is it team A or B? Next question.
No, next question is team A. Team A. Team A.
Okay, team A. Yes.
So who first used the term apoplexy, meaning sudden strike from the above, to describe a large or fatal stroke?
Who first used the term apoplexy, meaning sudden strike from above? Total
No, Team A, what do you think?
No idea.
Okay. Yeah, make a guess.
Yes, Sami, make a guess.
Hippocrates.
Very good. Right answer.
Very good. Excellent.
Excellent.
Hey, thank you.
Excellent.
Good guess.
Next question for Team B.
Next question, yeah.
Mansoor bhai, CPD, CrossFit Jacob.
Number one.
Oh, they have a 90%, bhai.
No, B. I think Mansoor B.
Does not.
Does not have a more than 98% mortality.
I think it's B.
I think
rabies.
No, rabies से भी मर जाता है.
No, rabies is
100% है ना mortality rabies की.
African trypanosomes.
Yeah, I think it's African. Yeah, I think so. Yeah.
That's the only because cryptococcal rabies and you got.
Yeah, I think it's African trypanosomes.
African trypanosomes.
Okay.
African
trypanosomiasis. Okay. Are you locked this answer? Team A, would you like to have a guess?
Kidding.
Team A.
I think it's
Right. So rabies.
answer.
Streptococcal होगा अब तो यार.
I think it's rabies.
Meningitis.
This is 100%.
It's streptococcal.
Plus one, Sami, streptococcal meningitis.
Meningitis.
अरे
यार मशहूर में कह रहा था यार क्या हो यार.
Thank
क्या हो
you.
मशहूर.
Meningitis has a 60 to 80% mortality. All the other diseases, the top three have got more than 98%.
यार हर एक को amphotericin भी देते हैं सही जाती है यार. Come on.
Meningitis. Did you get it? Mansoor?
Yeah, I did. Yeah, you got a point for that. Yeah.
Okay, Team A.
Who invented?
Team A, who invented stethoscope in 1816?
बताओ भाई ये बताओ.
Team A.
स्टेथोस्कोप लगा के घूम रहे होते हो बताओ.
या पहला वाला जो है.
Renal, the first one.
Okay, the first answer.
Lennox.
Okay, you awarded 2 points. Well done.
मान भाई को नाम पढ़ना नहीं आया.
So what's the answer? A?
No, they said Rennie Lennox. That's fine.
Rennie Lennox, fine. Good. Correct.
Team B, and the last question now.
Question Team B.
576 megapixel.
56.
576 Shiraz.
Confirm.
576.
Yes.
Confirm.
Confirm हो गया. Shiraz भाई ने बोल दिया.
Okay, well done, Shiraz. And well done, Team B. So who is the winner, Naseem?
Obviously.
Calculating.
Team B.
Obviously.
Obviously.
Oh my God! 12 each.
Wow!
ये तो cheating है भाई.
Excellent. Well done.
Great work.
एक तो भाई वो कर लो एक.
क्या कर लो?
Sudden death.
एक और sudden death कर लो.
अच्छा मेरे पास है एक question.
जुमला बता दे कोई.
अच्छा मेरे पास एक question sudden death का. Shall I ask?
Sudden death है.
Yeah, go for it, Mansoor.
Go for it. Shall I ask? Okay, that's fine. I will ask the sudden death question. Let me just get my quiz.
Okay, I have one question. Which DOW 2002 went for Hajj in 2019?
शहजाद शमीम के बच्चों के नाम बताए सारे.
शहजाद नहीं बता सकता.
I'll just one last question. Which country's prime minister won the 2019? Which country's prime minister won the 2019 Nobel Peace Prize? Was it Nigeria? Was it Kuwait? Was it Bhutan? Was it Ethiopia? Which country's prime minister won the 2019?
Ethiopia.
Who said that? Which team? Which team?
Ethiopia.
Okay, it is Ethiopia. Well done, Mashood's team. It is Ethiopia.
Both said Ethiopia. That was easy.
Amia's team has been saying Ethiopia.
Well done.
Both said Ethiopia.
Oh, you both said Ethiopia. Okay.
No, we said first.
Right, I have a question.
We said first, Mashood.
I have a question. How many PhDs in our class?
भाई इतना मुश्किल सवाल नहीं पूछ भाई.
Ask a very easy question and $1 million question. Name Sri Devi's first Hindi movie and her last one. Name Sri Devi's first Hindi movie and her last one.
Last one तो ये जिसमें वो टीचर होती है क्या नाम थी?
Mom.
पहली वाली इंडिया नहीं.
Mom.
And first ever Hindi movie.
First ever दोस्तों पैदा नहीं हुए थे.
You're right. You're very right. उससे पहले हम लोग नहीं हुए थे, लेकिन what was it?
जब हुए नहीं थे तो देखी भी नहीं भाई।
तो मैंने तो देखी है ना।
तू पैदा हो गया था ना, तो नहीं मैंने।
16वां सावन।
What's the question, Mansur?
So name Sridevi's first Hindi movie and her last one.
Yeah, it
Last
was
one to
16वां सावन.
Okay, I will take that. Solva Saban as a heroine. Well done, Maz. Which team were you in?
माज गूगल कर रहा है, इतनी नॉलेज है नहीं उसके पास।
आज एक गूगल में देखा है।
I think Team Mashood wins here. Team Mashood. Yeah.
Yeah.
Yay. Well done.
You need a better team next time.
Come on, Naseem. Now the final presentation award.
Yeah. I think. So guys, I've just muted all of you. Thank you very much for participating in this good fun exercise. So we had about 20 odd presentations this year, 2 speakers in each webinar. And what we did is we did a survey, and you have received the link. So we asked you to nominate the best speakers, the best presentations of 2019. Now, some of you suggested that we just go ahead and just choose the speakers ourselves, but we thought we could keep it, very democratic and ask you for your feedback. It was easy for us, to pick the names ourselves, but we decided to go for the survey option. So we received a few responses, and we had some really good presentations from everyone. Saqib, Shehzad Shamim did an excellent presentation. Mason's talk was very good, and so on. But we got the results, and I'm just going to share the results with you. So I'm going to start with the third prize. Give me 1 second.
You're right.
So the third prize goes to Maz Abid for giving us a talk on skin dermatology cases. He received the third most number of votes. Second prize goes to Mazhar Mirza for his talk on positivity. And interestingly, what happened is that we have got a tie for position 1. We received exactly the same number of votes, which is 16 votes for position 1. So there was nothing really to choose from. So we decided to give a joint first prize to Momin Qazi for his presentation on digital healthcare, and Yawar Saeed for his talk on cardiac arrhythmias. So congratulations to Yawar, Momin, Mazhar, and Maz Abid. So I'm just going to...
Congratulations, guys. I think you need to unmute them.
Yeah. I'm doing it now.
You need to unmute everyone, yeah. But congratulations, Maz, Mazhar, Yawar, and Momin Qazi. Well done.
Congratulations. Well done.
And thank you very much to Mashood and Samia. It was wonderful. Lots of hard work into this. And inshallah, we'll all meet in January. And basically, please forward me the names, presenters for January onwards. And then we'll have more fun in the future. And please make sure that you guys keep on attending these webinars. And we'll talk about the timings, and we'll see if we can actually rearrange that for us, for our Australian colleagues in Pakistan, as well. Thank you very much. Thank you. Bye now.
Thank you. Allah Hafiz.
Allah Hafiz, bhai.
Okay,